Nursing staff at a long-term care facility report that Dorothy, who has dementia and has lived at the facility for 2 years, has been exhibiting increased agitation for the past 2 weeks. About 2 weeks ago, the patient's family brought in a mirror for Dorothy's room because they noticed that she was not keeping up with her appearance as she had in the past. And in the past, Dorothy had really prided herself on her appearance. A nurse entered Dorothy's room and found her frightened and staring into the mirror. The nurse asked Dorothy what was wrong, and she stated, "That old woman won't stop staring at me." Ms. Buckner, this case shows how Dorothy's environment may be affecting her behavior. Please describe how you would provide a patient-centered environment for Dorothy and collect the information necessary for her care.
I would start and meet with the patient, Dorothy, and consult with her to see where she's at and kind of meet her where she's at. I would ask her to kind of tell me how she feels when she looks at the old lady in the mirror, and try to see what kind of feelings it brings up for her. If she says she doesn't like it, and she doesn't like the old woman staring at her, I would then go to the team and to the family and kind of educate them on what she's feeling. After that, if she is not responding well to looking at the woman in the mirror, I would probably recommend that we take the mirror out of the room. And then also I'd educate the family on the process of the stages of dementia and help them understand maybe where the patient is at and what she's feeling and going through. And then just have some good open communication with the team about the different feelings that the patient's having. Another thought too would be to try to see maybe what the patient enjoyed and what the family thought were some of her highlights of her appearance, if it was lipstick or makeup or getting her hair done. And if, you know, maybe they thought that would be something that could be beneficial to help her kind of be more comfortable instead of looking in a mirror when she might not recognize that that's actually her.
Ms. McBride, what activities would this patient benefit from to enhance her quality of life and enhance cognition?
Okay, well, I'm glad you asked that. As you know, as people progress in their dementia, they lose some of their language skills. So my first assessment of that patient would be to do a speech-language assessment and further dementia staging, because you need to work with the staff to train them as to what the patient's able to still do in terms of communication. Now, this particular lady had not been grooming very well for several weeks, so this was not a sudden onset. The mirror was the trigger. However, something happened in the weeks before the mirror went up that triggered her not to be as responsive to grooming. In many cases with dementia, as it progresses, patients have what's called agnosia, loss of understanding of how to use utensils. So it might indicate a progression of her dementia. So a good thorough assessment and restaging of her dementia will help train staff so that they'll know how to better help her be functional. She may be at the point where she literally needs to have more help with her grooming than she did previously. Secondly, we would always want her to be able to remember that which she can remember. So going back to her early marriage, her raising of family, we know she has a good, caring family. They need to bring pictures in. They need to write down on those pictures dates, family names, big events, because those are the things that will remain with her the longest. Put them in her room so that caregivers coming in and out can address those things with her. put the prompts on the back of the pictures so the caregivers can read and know how to discuss the topic. What we would also recommend is reminiscence therapy in a group, going back to the era she was raised with, the music that she loved to hear and the dances or the big events of that time in her life to help her remember things.
Dr. Parrish, as the patient's primary medical provider at the facility, what next steps would you take?
Great question, Megan. When we have a behavioral change in a patient, honestly, what we hope for is that it might have a medical cause, because more often than not, if it's medical, we can fix it pretty easily. So I do think a medical workup at the time of a behavioral change is very important. Unfortunately, though, what we typically find is that those changes don't have a medical cause. But what we look at is just the entire picture. We're looking for symptoms through all 12 systems. We're doing a comprehensive physical exam. We're updating any labs that need to be updated. And we're following up with labs on any specific complaints. For instance, if the patient had a urinary complaint, we're following up with a urinalysis just to be sure that's not an intervening factor. In my experience, though, most often we're looking at a behavioral symptom of dementia, and that's going to be a more complex problem for us to deal with, unfortunately.
Bob, a retired Army colonel, has dementia and is living at home with his family. He has always had a strong personality, but as his dementia worsens, he has become increasingly angry when things do not go his way or he does not understand his environment. The anger escalated to the point where his family was frightened of him. Despite involvement of home health services, caregiver support, and optimization of his medical status, the family situation continued to deteriorate. He required inpatient hospitalization for delirium due to an acute urinary tract infection. In the inpatient unit, with a structured behavioral management program in place and very low-dose psychotropic medications, he became much more manageable. A family meeting was held and placement in an assisted living facility soon followed. Ms. Buckner, what stages and processes do you see families undergo when making the transition between home and into a facility?
I see the families go through the stages and processes, mainly the stages of guilt and grief. Grief is a big one, going through the grief process of what they thought was going to be and now what is really happening with their loved one, and educating them that they are still the caregiver. It's actually just a different type of caregiving, and that they can concentrate more on being an emotional caregiver rather than the burden of taking care of the physical part of caregiving. A lot of times we see patients come in and out of the hospital in acute care setting, and it takes the family several admits into an acute care setting before families realize that the patient is actually more safe and better off in a long-term care setting than they are at home. And so sometimes it takes several stages for the family to realize that this is better off for them, and especially for the patient.
Dr. Mosley, when psychotropic drugs are indicated, how do we best choose the medication and monitor for safety?
Again, that goes back to which psychotropic class we're talking about again, because there's so many of them. If we're talking about specifically antidepressants again, what we use a lot of time in our geriatric patients is going to be medications such as sertraline or citalopram. That belongs to a class of medications called SSRIs or selective serotonin reuptake inhibitors. With those medications, we normally keep track of how the patient responds to them. Are they sleepy? So is there increased sedation, or does it make them a little more active? And based off of those factors, we can move the medication to the morning or the evening. And those can easily be seen by other patients or other caregivers, and they can help us by communicating with us of how we can adjust those medications to better take care of the patient as well. And so monitoring factors just by how the patient responds in those ways too. There are laboratory parameters that we check for, sodium levels and things like that too. And then with antipsychotics, like we talked about earlier, those have more metabolic risks that we have to take into consideration. They can affect a patient's blood glucose or their blood sugar levels. And so we have to monitor those. It can cause some weight gain if they're kept on it for too long as well. And several other things, there are some movement disorders that can be caused that we also need to consider, especially if they're kept on the medication for long term. And so there's some testing that we may have to do at baseline and continue to do ongoing if they need to remain on those medications for long. Sedation is a big one that we have to monitor in older patients. Older patients have a harder time of removing the medications from their system, or what we call eliminating them, just because as we get older, our body just has a harder time getting rid of the medications. And so they tend to hang around a little bit longer. And because they're on so many medications, you have drug interactions and other medications that can cause sedation as well. And it just, all of those things start stacking on top of each other and accumulating. It just increases our risk of drug interactions and increased risk of sedation as well. And so those are a lot of the issues that we have to look out for.
Dr. Parrish, as this patient's primary medical provider, how would you approach this case?
This is a tough case. When we think about dementia and the trajectory of the illness, we think of a very interesting, unique trajectory. With processes like cancer or heart failure, a lot of times we think of a slow downward trajectory that's fairly linear. What we more commonly see with dementia is stages of stability followed by events such as medical complications that cause the patient to go into a more rapid state of decline, followed by another period of stability. And so in these sorts of cases, I find it really useful to speak with family, caregivers, support people, and other staff members, and just provide them support and education about what they've seen. It can be very scary to watch your family member go through one of these states of rapid decline. And in this instance, we're going to have an opportunity to provide them with a lot of support by giving them education about the medical underpinnings of what they've witnessed.